As occupational therapy professionals, many of us have witnessed the wonder of neuroplasticity in neuro rehab. Yet, despite years of research attempting to identify the most effective post-stroke interventions, the reality is that our understanding of how to improve recovery of function remains incomplete. The article that we are reviewing today serves as an update on the state of the science and how new theories of motor control and learning can be incorporated into practice. The authors put particular emphasis on how technologies may be needed to truly meet the many principles of neuroplasticity, and in particular, they point to virtual, augmentative, and mixed reality technologies. After we review this article, we will welcome to the podcast an OT who works for one such virtual rehab solution as their manager of clinical services, Katie Riccio, MS-OTRL. Katie will share what she has learned about neuro rehab in her role and orient us to the stroke rehab tools that are on the market, how they can intersect with your in-person practice, and what to expect on the horizon. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, and I am a licensed occupational therapist. Before we dive into this big topic of motor learning in neuro rehab, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform. But to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. So bearing in mind that this could count as a CEU course, I wanted to state our two learning objectives so you can be thinking about them throughout the podcast today. Our first learning objective is that you will be able to identify how virtual rehab can help meet the principles of neuroplasticity in OT treatment. And second, you will be able to recognize how virtual rehab can augment in-person OT. So let's begin by looking at this journal article, and then we will patch in Katie to discuss how this paper could play out in your practice. The article we are reviewing today is called Motor Learning and Neurological Rehabilitation. It comes to us from the Journal of Disability and Rehabilitation, and it was published in 2021. We are reviewing this article today because it was found on our list of the 100 most influential OT-related journal articles. This article was ranked 54th on this year's list. So the article begins with this introduction to motor learning in neuro rehab. Over the years, numerous studies have been conducted to identify the most effective rehab interventions for post-stroke upper limb recovery, but our knowledge of this practice area remains incomplete. Upper limb sensory motor deficits continue to persist in a large portion, up to 62% of stroke survivors for greater than 6 months. This means that the burden of upper limb impairment remains high. So what was the intent of this article? The authors of this article suggest that recovery potential may improve when upper limb training programs focus on remediating an individual's specific motor impairment with the framework of a motor control theory. So to support this conjecture, they review current theories of motor control and learning and describe how these theories can be leveraged in training programs. It is interesting to note that one author of this paper was trained as a PT and the other as an OT and are now research scientists. So this is about to get nerdy, but please hang with me and please dig into the article for the full complexity presented. I'm going to do quite a bit of simplifying for this one, but we promise to bring it back to your practice. So let's begin with these theories of motor control and learning. There are two major approaches or theories to motor control and learning. The first is the computational or the physical approach, which assumes that central processes directly control movement characteristics. The image I found to illustrate this computational motor control theory literally portrays the body as a machine. I will link to this in the OT Potential Club, but you can imagine the brain as that central computer and the programming then that goes into motor control. So in line with this computational approach to motor control, motor learning is then understood as a series of different systems that integrate information from the moving limb during task practice and then use this information to build a movement schema that can be stored and recalled when needed. So the way I understand it, this theory really pushes us to practice the same movements over and over until this schema is built in our central processing. But there is a newer theory that probably better represents how we see motor learning occur in the real world. And this theory is going to feel very, very familiar to OTs, even if you've never heard of it before. It just so aligns with OT practice, and that is the dynamical systems approach. In this approach, motor learning is seen as a model of person, environment, and task-related constraints that lead to movement. Literally, the model is that picture of three intersecting circles, the person, the environment, the task, and at the center is motor development. So that really aligns with our OT way of thinking of integrating these different areas for the completion of an occupation. So in a dynamical systems approach to motor control, the central nervous system is understood to govern rather than simply produce movement. There is a complex interaction between the neuromuscular system, the biomechanics of the body, and the object and environmental forces. Here's how the article describes skill learning under this approach. The mastery of degrees of freedom is achieved through a problem-solving system that uses available constraints and possibilities to discover solutions to a movement problem. The approach emphasizes dynamic, exploratory activity of their perceptual motor workspace to create optimal strategies for performing a task and give rise to adaptability based on demands and constraints, end quote. So I'm sure you can already see how adopting one of these two theories is going to impact your rehab approach. So from here, let's look specifically at the general principles of exercise-dependent neuroplasticity and how they intersect with the dynamical systems theory. So when a motor learning theory like the dynamical systems theory is combined with the 10 principles of neuroplasticity, we really start to get some concrete guidance for rehab. In particular, the authors highlight the importance of intensity, repetition, and salience. I think I'm going to make a handout of these 10 principles of neuroplasticity just to keep them fresh in our brains, and I will link to that in our show notes. But focusing on these three ones that you're probably the most familiar with, intensity, repetition, and salience, let's look first at the definition of intensity in rehab. We know that rehab should be delivered at a high intensity, i.e. dose frequency and duration, and involve challenging practice. However, the definitive number of repetitions actually needed for motor learning post-stroke is unknown. One thing that we do know is that compared to healthy individuals, it takes more repetitions for individuals with a neurological insult to achieve improved motor outcomes. In one study, which I'll link to, healthy participants required around 20 repetitions to improve their performance for a reaching task. Individuals with neurological deficits required more than twice that number, or 55 repetitions. So there's a lot out there about intensity in our neuro rehab, but suffice it to say, we probably need more than what we're doing, even though we don't know that exact number of repetitions. Looking at training specificity, while intensity is an important piece of the puzzle, it is not on its own enough to improve function, and neither is specificity. As the authors point out, results of training programs for improving upper limb function have not demonstrated carryover to functional movement. These have been those kind of studies where one motion is done over and over and over again, and maybe the person gets better at that one particular movement, but that doesn't carry over to their functional movement, to their daily life, which is what we are going for as OTs. And this is where that theory becomes really important for us to understand, because in the dynamical approach, less emphasis is placed on reproducing an optimal movement pattern. Instead, this approach focuses on learning a set of movement patterns that might be equally acceptable in light of the constraints presented by the environment, the specific task, and the learner's condition. Another principle of neuroplasticity is that the practice should be progressive and optimally adapted to the individual's capability and environment. Thus, to induce new learning, practice should challenge the learner, progress over time, and engage the learner in active problem solving. The challenge level is also related to motivation, another key factor in motor learning. In clinical and healthy populations, it has been shown that surrogate markers for motivation, such as self-confidence, hope, autonomy, support, and social relatedness, may play important roles in promoting motor learning. So from here, the article talks about the type of task practice. Task practice that is organized according to the person, environment, and task constraints plays another important role. The two main practice paradigms are blocked practice and varied practice. More comprehensive studies are needed to determine the benefits of both practice types. But in terms of alignment with theory, varied practice just better lends itself to active problem solving. And the last component of rehab that they talk about in relation to theory is the type of feedback and delivery. So while not mentioned in the principles of neuroplasticity, we know that the frequency and type of feedback matter. Of note in this section, there is strong clinical evidence suggesting that individuals' knowledge of performance post-stroke may lead to better motor learning outcomes and retention than knowledge of results. And that knowledge of performance is just that more ongoing in the moment feedback that happens during the movement versus knowledge of results, which, for example, would be I moved the cup, whereas knowledge of performance would be feedback on how that movement actually happened, which honestly is harder to give than just knowledge of results. So after going through a lot of detail on how this dynamical systems approach intersects with the different components of neuro rehab, the authors close with talking about the applications of motor control and motor learning principles in neuro rehab using VR. There are clearly so many considerations for motor learning post-stroke that is difficult to align theory with neuro rehab practice in our traditional rehab settings. Just looking at repetitions alone, the general consensus is that the number of repetitions performed in OT and PT session in both outpatient and inpatient rehab centers is inadequate. For example, in a study that I'll link to, the average number of upper limb repetitions was only about 32, whereas we're ideally looking at repetitions that are in the hundreds. So the authors propose that rehab technology is poised to address not only the problem of practice intensity, but also practice structure and feedback. The authors spend quite a bit of time talking about what this could look like hypothetically, but thankfully, I am just going to talk about this in detail with our guest who is coming onto the podcast to talk about what this can look like in real-world scenarios. Honestly, the technology here is developing faster than the research is, so I thought it would be most helpful to just talk to someone who is boots on the ground with this technology. So as we head into the authors' discussions and conclusions, they say that in summary, VR applications have the potential to provide high repetition, varied practice in changing environments to engage learners in active problem solving. So while we need that intensity, we need specificity, we need varied practice, that active problem solving really is our goal in motor learning. These VR systems can also incorporate monitoring and in vivo performance tracking to continually assess whether the challenge is optimal while also providing real-time feedback. This paper has given an overview of the theory of motor control and learning principles that will help therapists evaluate VR options and ultimately move the field forward to improve the lives of people with disabilities following neurological injury. Okay, there was a lot to take in this paper. I do think there are nuggets that could help you in your traditional OT practice, but really the heart of this paper is that we probably need technology to really be meeting all of these neuroplasticity principles to really be meeting the components of motor learning. And I left just curious, what does that logistically look like? And I'm so thankful because I found just a great person to talk to us about that. And that is Katie Riccio, MSOTRL. Katie has a BS in exercise physiology with a specialization in gerontology and an MS in occupational therapy. She has 2 decades of experience in adult rehabilitation across subacute, inpatient, and outpatient settings, as well as experience in upper extremity robotics research. Katie's focus areas include upper extremity rehabilitation, driver evaluations, neurological rehabilitation, and rehab technology. Katie is currently working for Neuro as the manager of clinical services, educating clinicians, caregivers, and clients on their upper extremity programs, utilizing their NeuroBall platform technology. And I do want to note that I thought long and hard about who to have on this podcast because we have actually talked about virtual rehab in the past on the podcast, but it was always pretty hypothetical. And for this episode, I just really wanted to talk just really specifically about the tools that are on the market and how they could augment your motor rehab. And there are multiple OTs who do work for rehab tech companies like this, but I landed on Katie because of her long background. Also working clinically, she really has that clinician brain that you'll get to hear. And the fact that she still does provide virtual rehab through Neuro. So she just really actively is thinking about the role of the clinician and how these technologies can help us. So without further ado, I will patch Katie into this podcast. Welcome to the podcast, Katie. It's great to have you.
Thank you, Sarah. Excited to be here.
Oh, I'm so thankful that you're here today to talk about this really big topic. I've kind of been thinking about it on 2 hands this morning. One, we know stroke rehab is the leading cause of disability worldwide. We know more people are surviving stroke. We know we're getting older. We just know the huge numbers of people who could use more stroke rehab probably than they're getting currently under our current systems. And then that's one hand, just there's a lot of people who need it and probably more people will need it in the future. And 2, as a therapist, stroke rehab is complicated. Like you think about all the points that this article touches on and all the things we need to hold in our mind as therapists. And it's pretty overwhelming. And with both of these things together, you're like, we need the support of technology, both to get stroke rehab to all the people that need it and just to support us in our sessions because it is so complicated. So I'm so thankful that you are here today because you straddle technology and have this experience of being an OT, of providing an OT, and can kind of talk to both sides of it. So you are the perfect person and I can't wait to dive in, but I want to start just with your story and how you got to where you are today at this really interesting stroke rehab company.
Sure. Great. Thank you. And happy to share. I think my journey started like some other therapists, right? I got injured in high school. I tore my ACL and I went to physical therapy my senior year. So that is really what started to pique my interest into the therapy world. But I was always interested in fitness and sports sciences. And I went to Ohio University, where I received a Bachelor of Science degree in exercise physiology, as well as a certificate in gerontology, because I really wanted to work with the adult population once I graduated. So after graduation, I did work in corporate fitness, probably for about 3 months, but just I felt unfulfilled in my role, right? And so that's when I started to re-explore the healthcare fields. And a friend of mine introduced me to occupational therapy. As I researched it further, I was immediately drawn right to the foundations and in this holistic care and the opportunity to really make a meaningful impact, helping people return to function, right, post-injury and disability. So that's when I went to Towson University and got my Master of Science in occupational therapy. So from there, my career started in a skilled nursing facility. So I was working for about a year and got experience, right, with more patients in the subacute and the long-term care populations. And then after about a year of experience in subacute, a position opened up right at one of the top rehabilitation hospitals here in New York. So I transitioned over to Burke Rehabilitation Hospital, where I actually spent the next 18 years working with them critically. Yeah. So VERC was great. I was able to start at their inpatient rehab hospital, and you get to rotate around all of the different floors, right? So you really get experience working with patients post-orthopedic injuries, pulmonary and cardiac diagnoses and injuries, as well as brain injury and spinal cord. But then I found my way up to the stroke unit, right? And the neurological unit. And that was it. I didn't want to rotate anywhere else, right? So this is where I really started to develop my passion for working with patients post-neurological injury and stroke, and started to really become intrigued with using technology, right, to improve upper extremity function. So I did about a year after that with research, right, where I was able to really see how using upper extremity and end effector robot with patients with stroke, right, was helping them to really improve their function. And we were seeing patients 2 to 3 years post-stroke, up to 10 to 15 years post-stroke, make changes, right? So they were provided with this high dosage, right, which we'll talk about, right? Over 1,000 repetitions, 3 times a week for 6 weeks. And we were seeing functional gains with our subacute and chronic strokes. So once that study ended, I moved over into the outpatient rehabilitation department, where I was able to just gain more experience working with rehab devices, right? So getting a more comprehensive understanding and training. I was fortunate to use electrical stimulation, right? Functional electrical stimulation bikes, robotics, different exoskeletons, with or without EMG-based biofeedback. And then really was able to work with a lot of those sensory devices and wearable devices, as well as mobile apps, right? You see mobile apps, you see computer apps, and all of this is starting to incorporate this virtual reality and this augmented reality. And really, it was here that I was introduced to NeuroPhoenix. So I was using their upper limb technology with my patients, and I was seeing great results, right? They were increasing their dosage and increasing their intensity, improved motor patterns, improved outcomes. And so after speaking with the company and providing them feedback on the product, I just knew I wanted to be a part of this mission, right? To really help patients post-neurological injury increase what we're going to talk about, right? Dosage, intensity, and frequency through technology at home, right? So I initially joined NeuroPhoenix as a senior clinical specialist, and now I am managing the clinical services department and leading the development and implementation of their virtual therapy programs. So we're really combining the use of technology with occupational therapy services, like merging those two together.
That is just the best story because it feels so relatable. I also started in a SNF and SNF and then rotated around a trauma hospital, the different floors. And I think as you're doing that early in your career, it doesn't feel like you're preparing yourself for like a tech position, but I'm like, you totally are because you're really getting to know the patient experience and the therapist roles. I had one quick just follow-up question. Were you like trolling the website of NeuroPhoenix? Like I went to work there, or like, did you have a personal connection? Like that feels like a big leap. How did you land that job initially?
It's a great question. So at Berg, I was the lead therapist for technology. So I was coordinating, bringing in all of the different, the vendors, right? And so I had a close relationship with someone who worked at NeuroPhoenix, and we did a follow-up, right? So you always do a follow-up with these companies, and they want to know how you use the product in the clinic and what results you saw. And honestly, Sarah, after I got off the phone call with him, I wrote him an email and said, I want to work for your company.
Whoa.
That's
awesome.
how the connection happened.
Good for you. That's amazing. We're going to be talking about rehab tech kind of generally in broad buckets today, but I do want to be oriented to like NeuroPhoenix in your job there specifically. Can you tell us just a little bit about the product and how it fits in this larger stroke rehab ecosystem, and maybe what made you write that email? Like what made it stand out to you?
Sure. So in general, NeuroPhoenix is a rehabilitation technology company and a virtual service provider, right? So we're combining the use of our cutting edge technology with personalized therapy services, virtual therapy services. to help patients who are recovering from neurological injuries, and particularly post-stroke. So the combination really allows the therapist, right, to facilitate high repetition training through the use of the platform. But in return, it's also allowing us as therapists, right, to monitor our patients' progress and adherence in real time. So we're able to really provide continuous support, track their progress, and adjust their programs as needed. With NeuroPhoenix, they have a patented device called the Neuro Ball, and that was developed for patients to use at home, right, post-neurological injury to regain upper limb movement, range of motion, strength, coordination, but with the focus on providing high repetition and high intensity to induce neuroplasticity, right, and maximize recovery. And so that's really what kind of pulled me over, because I thought, how do we fill in the gaps, right? Our patients have 2 to 3 days of therapy in the outpatient clinic, but what are they doing for the rest of those days? And how can we really increase this intensity for our patients, because we know they need it, right? And so that's really what, made me make that phone call or send that email to the company. So with the NeuroBall, it is a sensor-based device. Obviously, it's shaped like a ball. It keeps the hand in an open, functional position, and it uses IMU sensors, right? So it's really detecting that rotational movement of all the pivots in your upper extremity. And then it connects to a tablet via Wi-Fi, right? A Bluetooth connection. And that's what really helps to keep the patients engaged, because they're using therapeutic games and activities, right, with the hardware. And so that gamification provides a continuous challenge to the patient while providing feedback, right, and external cues to keep them motivated. So again, thinking about increasing intensity and dosage. And how that fits into like the overall larger ecosystem into virtual reality is that it's a non-immersive VR device, right? So the patient's not fully immersed into that virtual world. Virtual reality, right, or they call it virtual rehabilitation in the article, involves the use of computer-generated environments, right, to simulate real-world scenarios. And we're using this in rehab, right, because it's providing those task-specific scenarios that can be adapted to the patient's needs, right? So we're really targeting motor learning. And with VR, right, you can work on increasing the challenge, the specificity, the intensity, the salience, all of those that we know are the foundations for neuroplasticity. There are different types of VR, right, devices on the market. So as mentioned, we have a non-immersive virtual reality device where the user interacts with the environment, and it's usually through a screen or a tablet, right, a computer, a smartphone, but you're not fully immersed. It often involves the use of a controller or a wearable, right? And they have pressure sensors or IMU sensors to detect movements. And sometimes it's just an app on a tablet, right, where you're working on visual therapy or cognitive therapy. There's also fully immersive virtual reality, right, where the patient's completely immersed and surrounded by a 3D environment, right? So it's creating that sense of being present in the virtual world. And this typically involves, like a VR headset, helps to block out the real world and puts you into this virtual one where you can really focus on task-specific training. And then there's also augmented reality, right? So these are where digital elements are superimposed into the world, right? Kind of blending that virtual component with the user's real environment. So you'll see this through smartphones or tablets with motion tracking software or like video capture tracking systems, and that helps to blend the two together. You'll see now that there are companies that use glasses that allow you to interact with the real world with a digital overlay. Yeah. So in general, that's how we fit into the whole scheme of VR there.
Mm-hmm. It feels like where we're at in stroke rehab right now is we know we need technology to help us meet the complexity of stroke rehab to get those high levels of intensity, but there's not really a gold standard of like, this is the exact way to do it. There's still a lot of, the therapist still has a lot of discernment to find the right fit for their particular client. And like you said, there's a lot of different options out there that might be the right fit for your particular client. And turning to this research, or to this specific paper, it was, to me, it was a lot to take in like the theories presented. But the more I read it, the more I was starting to feel like this is almost like a checklist of questions that we should be asking these technologies. Like, is it helping us meet these different components of stroke rehab, the principles of neuroplasticity, and the components of the dynamic systems approach? And also just to be asking of our own in-person stroke rehab too. Are we trying to pull these elements together as much as we can in our in-person sessions as well? And the part that really stood out to me, I love that dynamic systems approach and the heart of it being problem solving. That to me was like the key check mark. Like, are you actively problem solving in your tasks? Like, if you're just doing cones, there's no active problem solving. And you could be on a sweet, fancy VR thing, but if you're not problem solving and it's just rote movements over and over, you're probably not getting the full benefits. That was my takeaway from this big article. What were your takeaways? You're so much more immersed in it.
Yeah. No, that's a great outlook from it. And I agree, right? Because we have to problem solve in our everyday life, right? One task is not always going to be the same, right? Reaching for a glass in the kitchen versus in the bathroom, right? Depending on the environment. And so I think from the research, I thought it was a great overview of the different theories, right? And I liked how they compared the computational approach to the dynamical systems approach, but more as if the dynamical systems approach kind of expands on the computational, right? So for example, right, with computational, we know motor learning occurs right through a series of different systems, right? So our attention, our perception, the forces, the velocity of movement, like all of those are going to help us to develop a scheme, right? And a generalized motor program. So as you mentioned, if you're just reaching for a cup 400 times in the same direction, yes, you're going to develop a generalized plan. But then using that dynamic systems approach, right, we take that scheme and now we want to see how are we interacting, right, with the individual and the environment, right? So how heavy is the cup? Is it plastic? Is it glass, right? Are you standing? Are you sitting? Are you weight shifting? Is there an obstacle in the way while you're reaching? So I think that dynamic system approach really focuses on that variability and how it affects our motor planning, right? As we problem solve, right? And as we discover new solutions. So that reaching pattern will never be the same depending on, our individual restraints and environment. So I did like that. And I did like that both models really stress the importance of task relevant training and that we need to incorporate that into our sessions, right? Obviously, we're doing that as OTs, but it's always good to have reinforcement from the evidence as well. I also, liked that they went over general principles of neuroplasticity in the article and helps reinforce our strategies that we're using with our patients, right? Post-neurological injury, looking at salience, repetition, and intensity as being key drivers to neuroplasticity and recovery. And I thought it was great, right? It just, again, reinforces that we need to deliver this high intensity, progressive levels of change to our patients. And as you mentioned, they have to be an active learner in this problem solving, right? And we also have to motivate and provide rewards so that we can reinforce that learning. Yeah, so I agree. I thought it was a great article, a lot to unpack. But once I read through it a few times, right, like you mentioned, it just really makes sense and helps reinforce what we should be doing with our patients in therapy.
Mm-hmm. Yeah, and really in reinforcing of that OT approach, like considering, like the dynamic systems approach just looked like an OT approach, and really lent itself to our way of thinking. I want to get into like the practical, like therapist side of your brain and ask, I guess starting just with like the theories presented, were there like practical takeaways that you had as a therapist that either reinforce or would like push you to do things a little bit differently in your sessions?
Yes. And I think there's 3 theories I really pulled out. Obviously, We keep talking about this dynamical model of motor learning, right? So as OTs, we're always looking at the interaction of the body, the environment, the task, right? And that's the three words that kept coming up through this article. But I did find it interesting that they kept using the word constraints, right? What are the constraints that we're encountering from our environment versus what are the constraints that we're encountering from the person's impairment, versus what are the constraints from the task itself, right? And so it really, really reinforces that we have to analyze the environment, right, and the situation in which our patients are completing the tasks. And they have a really great picture in the article of a person, reaching for a messy desk, right? So it's a great illustration of how your motor control will change based on the environment and how the task is set up. I also really liked that they discussed the concept of kinematic abundance, right? So it just basically means that our body has many different ways to move and complete a task, right? There's no single correct way to do something. There's always multiple solutions. And so the brain doesn't just find one way to perform a movement. It can find multiple solutions. So I think, again, just reinforcing that, look at the environment, right? How you're positioned or where you're reaching versus what you're interacting with, right? Is it soft? Is it firm? Is it lightweight? Is it heavy? That will help your body discover different ways to achieve the same task. So again, variability is really important for learning, especially in rehab. And it's also allowing us to explore different ways to challenge our patients, right? Really challenging them to move differently, practice standing, practice with weight shifting, practice while you're seated, right? So just really challenging our patients in what they'll be doing in real life, right? And then the last theory that I, really enjoyed reading about too was that practice should be challenging, right, to induce learning. So the challenge point theory. Learning is going to improve the most when the difficulty of the task is matched to the patient's skill level, right, and the complexity of the task. So we just need to make sure that we're pushing our patients enough, right, so that they'll get better, but not so much that they're going to get frustrated, so just finding that just right challenge for our patients, which is what we're always doing through grading our tasks, right, up and down. Yeah. So just finding the ways to challenge our patients to help them improve and learn new skills.
Those theories are so helpful. I feel like they are what we try to do in OT currently, but they also highlight how technology can be a support for us. We know it's just so hard to get the number of repetitions we need. We know it's so hard to keep grading that challenge by ourselves. Like there's ways technologies can help with that. And there's ways that technology can help give that real-time feedback. Either when we are there or when we're not there, technology can also be helping with that. Can you help me understand the interplay between our traditional in-person rehab and these virtual rehab options? And I guess maybe paint a picture of the ways they can be weaved together. Like I assume you can be incorporating virtual rehab into your in-person segment or into your in-person treatment, or it can be something that's done remotely and you're monitoring. And how do you see that interplay and how it can be most helpful for our patients?
Sure. Yeah, I think with virtual technology, I see it as a complementary system, right? Each approach can enhance each other, but I definitely see that we can use it in multiple different scenarios, right? So for in-person rehab, right, and especially when I was in outpatient rehab, right, using that technology during your sessions helps to increase repetition and intensity. So, for example, when I was working in the outpatient clinic, I had a patient and we were working on an upper extremity task, and I was able to help her get 100 repetitions. But then I added in virtual technology and she completed 400 repetitions, right, in the same period of time, right? So it really works to help us get a higher dosage with our patients. So utilizing it in the clinic with your patients for sure will increase intensity. I also see that we can use it in between sessions, right? So if a patient can access technology in between sessions through a virtual app or a virtual device, then this helps to provide an extension of their care outside of the clinic, right? And in between visits. So this could happen in an inpatient setting where patients take the technology back to their room, right, and can work on it in between visits. Or this could happen in an outpatient setting, right, where they can use the technology at home in between sessions. And then the third way that I see virtual technology being used is at home, right? So certain patients can't access in-person rehab due to geographical constraints. They live too far away from a neurological center, or they have no transportation, right, to get to a clinic. So virtual therapy can really help to increase their access to care. And then just, building on that as well, if they're using the therapy at home, right, certain therapies you can use on your own, but then you can also pair that with a virtual therapist, right, to really increase personalized treatment, progressive challenge, and intensity. So you can use it across the continuum of care. I also know of certain hospital systems using it more on the acute side as well. Again, because that's when you're really focused on ADLs, but we also want to make sure that we're addressing upper extremity earlier on as well too.
If I'm a therapist and I'm evaluating the different options for my patients, I'm going to be thinking like, are the tech options I'm looking at, are they meeting this checklist of like these neuroplasticity principles that we talked about the dynamic systems theory? Is there problem solving? What's my ideal vision of how this could interact with in-person rehab? But all of this is going to lead me to the question of how do we pay for this? What are the different payment models out there that we as therapists should be aware of as we're thinking of trying to match the right technology with the right patient? What's on the market for us as far as getting these paid for?
Yeah. That's a great question. And there are definitely different answers, right? Some certain technologies are paid for outright, but that's not usually the case, right? We're finding that, insurance isn't always covering these technologies, unfortunately. And some can be rather expensive, as we know. We also have therapists, again, utilizing this technology during their sessions, right? So that they can bill through insurance using the appropriate CPT codes. But oftentimes patients are paying out of pocket for the devices. Some companies do an outright purchase, but other companies also have subscription models, right, where patients can pay a month-to-month fee, or they can pay a rental fee, right, if they're renting the device for a certain period of time. So I think there's lots of options. Also, there are grants, right, and private funding. So sometimes certain organizations will help to pay for a virtual rehabilitation device. And so I think it's a tough answer because there's so many different options, but, best to reach out to the company that supplies the device or the service, and then they can really help guide you. But yeah, I think that's one of the barriers to the virtual rehab is that sometimes it's not covered by insurance or it can be too expensive. And yeah, so that's my long, short answer.
Yes. Yeah, it's hard because we see these technologies making stroke rehab more accessible. That's like part of the promise of them. But figuring out the payment models and reimbursement is one of the challenges that we have to layer onto an already really challenging list of things to take into account for stroke rehab. And I'll just be curious to see how that develops as the cost of these things I anticipate will come down. But yeah, that will definitely be something for us to follow as therapists and that we just have to be aware of. You have been immersed in this technology. I imagine you now have just so many personal stories that you've racked up over the years, getting to interface with the technology and patients. And I'm just curious, what you have learned from seeing these patients get these higher intensity levels in their rehab. And I guess I kind of want to put you back at if you were still in a hospital or an outpatient or even in that SNF, what would you do differently now seeing what you've seen? Yeah, what have you learned that you can share with the rest of us?
Yeah. That's a great question. My short answer is I would start earlier and provide more intensity, right? And I think with all of the evidence coming out now is that we know we can start earlier with a higher intensity program. I think we're all aware, right, that the research shows we're not doing enough repetitions in the clinic, right? Observational studies show we're doing 32 reps, as an average. But we know we need to push our patients, right? 300 to 400 repetitions and even up to 1,000 to induce neuroplasticity. So what I've learned is that we need to do more, right? And how can we get there? And can we use technology, right, to help us get there? For me, yes, it's been exciting to see in real time that patients are completing 1,600 to 2,000 reps in a 45-minute session, right? So that's fantastic, right? I could barely get to 100 with my one patient, and then helping with technology, right? We can push up into the hundreds and the thousands. And so I've seen that intensity is definitely increasing, especially as more therapists are aware of what's out there, right? And technology is becoming more accessible, right? I think we're seeing more commercialized products. And so we're able to push our patients with the use of intensity. I also see that the intensity and the repetitions are getting more task specific, right? And more challenging. So back at my initial research, right, with robotics, we were having our patients do those 1,200 repetitions, but it was the same movement pattern, right? So they were just making a circle. But now technology is progressed, right? We're seeing gamification. So you can facilitate the environment, the challenge, right? You can give this feedback that's helping patients do a larger range of motion, right? Move in different directions, work more pivots of the upper extremity, and do task-specific training. So I think in general, yes, that intensity is increasing and it's getting better with the quality. And then I think also utilizing apps for patients, right? Can't we give them something to look at that's going to count their repetitions, right? That's going to count the change to push them further, right? So like in our program, we push the patient, we put a little number up at the top of our app, and we want them to do 400 repetitions, right? So this is helping, right, to increase that intensity and get them to that point. And then just the opposite with technology, clinicians can see the data, right? So we can push our patients more. Yeah. So overall, yes, I would start earlier, do more repetitions, and utilize whatever you have, low tech, high tech. It doesn't matter. There are so many therapists sharing ideas too now through social media and through different platforms. And so there's so many options on how we can provide that intensity to our patients earlier. Mm-hmm. Yeah.
Yeah, just to get visions of what's possible. Like when I started, I wouldn't have thought 400 reps was possible. I just wouldn't have thought that, but now we know it is. And yeah, and we all saw the earliest versions of this where it was just like one motion over and over and over. And then that was great at getting better at that one motion, but it didn't generalize. And now we're able to do repetitions with more variation and like you said, task specificity. I guess thinking, so again, back in your like taking your brain now and putting it back into that outpatient acute care therapist, thinking not only of intensity, but what you've learned about creating that progressive level of challenge. And then, like this paper said, I love the little part on knowledge of performance, not just knowledge of results. How would you take what you've learned about those two things? What would you have done differently in those more traditional roles, now knowing what you have seen and what you know now?
Yes, right. So knowledge of results is our end result that we're seeing versus that knowledge of performance. We're really looking at what's happening, right, while we're completing that task.
Yeah. Which is harder to give that feedback.
It is, but that's really
that sounds challenging to me as a therapist. How do I do that? What does that actually look like?
Exactly. But that's really where the change is happening, right? And so how do we progressively push our patients? Because we know that that's what's needed to drive neuroplasticity, right? That's what's going to help us improve motor recovery. So, always just gradually increasing the task to keep our patients progressing. And we want to make sure that we are using feedback, right, to help them to progress. And so, we discussed this a little bit, but, how far is the patient moving through their range of motion to reach the target? Okay, they were able to reach the target, so let's push that cup a little bit farther down, right? And so we have to just progressively change what they're doing and challenge them so they'll get better, right? Instead of, like we said, reaching for that cup straight out in front of you, let's go out into scaption, into abduction, right? And so really start to, push the patient into different environments. And so I think that this, the gamification helps to offer the progressive challenge with our patients, and it helps them to advance to higher levels, right? So as they improve within their function, right? So if they're improving their motor control and they're improving by moving faster, right? This rehab technology then will progress the patient to the next level, right? And so I think that's what we're seeing too with technology, is that the technology is able to progress the levels of challenge, but then we're also providing the rewards to keep the patient motivated. Yeah. So what I've also learned too, extrinsic feedback is extremely helpful, right? Error-based learning, right? We want to make sure that our patient is refining their skills and improving their movements throughout time. And so when we're using virtual rehab, there's many ways to do this, right? We can provide visual feedback to our patients, right? So for example, having to move a spaceship side to side, did I increase my range far enough to get around the obstacle, right? Did I squeeze my hand hard enough to pop the balloon, or, to make the person jump, right? And so providing this feedback is going to help that patient too to get stronger, right? Because maybe they weren't able to pop the balloon those first 5 squeezes, but as they're working harder, right, intensity is increasing, then they're able to pop that balloon. Yeah. And I think the other feedback that's really important from this virtual rehab too is that we can give sensory feedback and vibration, right? Like haptic feedback, which is also another piece of the puzzle. And that's going to help, provide patients with more sensory stimulation, as well as auditory feedback, right? So we can use a variety of ways to help progress our patients through feedback.
I actually did a past podcast on virtual reality and OT. And if I'm remembering correctly, we ended with kind of like, I can't wait till the haptic feedback comes. Like this was a couple of years ago, and it was like just barely on the horizon. And I'm like, now we're already there. And I think my question is, we've seen the earlier versions of this kind of stroke tech support, where like the robotic, where you do the same motion over and over and it helps with that one motion, but it doesn't generalize. And now we're at a better and more exciting phase of virtual rehab, where we have haptic feedback. We have more differences in the movements being performed. It's gamified. But my question is, what's missing from where we're at currently, and where do you think we're going on the near horizon? Like, I think there's exciting technologies. Like, I don't think we've fully arrived yet. Like, I think we're still learning and getting a little better. What do you see on the horizon for us?
Yeah, I agree. Well, first, what remains missing, I think, is access, right? I think there's just so many patients are unable to access this technology. And we know virtual rehab tools will help us. I also think what's missing is that therapists are not always exposed, right, to virtual technology and the options. So they're not able to use it in the clinic, right? And it's underused. I think therapists also have a limited understanding of what options are out there. So what I see on the horizon, yes, I see that we're going to continue to improve with the tools that we're developing. I think, again, through education and social media, we're seeing more treatment options. And so I think the awareness is growing, right, with therapists. And so my hope is that, right, all of this evidence is going to get into the clinic faster, right? So by collecting all these metrics and all this evidence, we're going to get rehab technology into the clinic faster, which then, yes, I think will improve what we're using and provide new options for patients, definitely. And again, I also see on the horizon virtual programs, right? So now that we have more accessible technology, right, that patients can use at home, I think we'll see more of a combination of therapy partnered with rehab technology, so we can really improve access, for our patients. Definitely.
By that, you mean someone seeing a virtual therapist and that therapist is using rehab tech?
Yeah, the patient has it at home, and then they have the therapist guiding them virtually, right?
Yeah, I can see that opening access up for so many patients. And I always think about that chronic phase of stroke too, and how many patients I discharged who would have been motivated to keep going. They just didn't fit in my traditional outpatient system. And maybe I wasn't being creative enough as a therapist, but I know if there was like that virtual option, they would have kept going. They had that motivation.
I agree. And that's, yeah, that is what we're seeing too, right? Patients are looking for options and, what can they do at home on their own too, right? To continue with the therapy. Because, yeah, as you know, there's certain limitations in outpatient, right? They get so much time with that in-person therapist and then discharged home, whether it's from insurance options, whether they're not making enough progress, right? And so I think having these options is great for patients to continue with their rehab because we know it's a lifelong rehab for them.
As I hear you talking, I feel, I want to say like burdened as a continuing education provider because I'm so focused on like, here's the new research that is coming out. But on the other hand, there's all these technologies coming out. And how do we stay educated on them? And I guess I'm interweaving this even with like thinking about the AI clinical decision support that's going to come to us in our documentation. Like, does that need to be suggesting different technologies to us in ways for it to get paid? My question is how in the world, Katie, are we going to keep up? And how do we as OTs position ourselves as the leaders in that? Like, you've been such a role model. What's your advice to the rest of us? Because I'm excited, but I'm honestly overwhelmed by it.
Yeah, it's a lot. Yeah. I mean, I could tell you, right, 2 years ago, right, kind of jumping into the health tech world, and I have learned a tremendous amount in the last 2 years, and I really appreciate it. But right, you've just got to stay up to date, right, with the latest technologies and the research. But we have so much access, right? Going to conferences, attending to webinars, listening to podcasts. There's so much information to ingest, but I do think there's just so much sharing now within the industries. Network, I think we all say this, right? Network and collaborate with others in the field. There are so many therapists that are involved with technology right now. And whether it's the user experience role, a clinical specialist role, right? Medical device sales, product development, but network, collaborate, right? And learn about this technology for sure. And then if you're in it, and once you're in it, measure your outcomes, share your case studies. There's so much data that's being collected that it's important, right? To share what we're learning to help push the field forward. But, and then I would say, join the team, right? We have such knowledge in task analysis and body mechanics and functional movement patterns. So, OTs can really help develop these virtual tools. So just bringing our knowledge of patient-centered care to help, with developing features and providing a successful user experience, right? So there's so much that OTs can do, but yes, get involved. It's hard to know. Yeah, it's always evolving, right? As you said, so it's hard to know everything. But I think, having, updated webinars about, new technology that's on the market is a great way to start.
I've loved getting this glimpse into your career. And I think you've just done, you as an individual, like showcase to us as OTs what's possible. One, your trajectory from that first SNF to being in this tech company, like on this ride that I would guess you would never have projected because where you're working didn't exist when you started. So you show us what's possible from just a career trajectory, but also then what's possible for our patients, like you're saying, these higher levels of reps, like really meeting these principles of neuroplasticity that the article laid out for us, and all in this dynamical systems approach where there's problem solving at the heart of it. We've talked about so many things. We've talked about theory, we've talked about tech, we've talked about career trajectory in this episode. What's the closing thought that you want to leave us on?
Yeah, I agree. A lot of buzzwords today, right?
Yes.
Task training, high intensity, progressive challenges, but I think
Yes.
it all came back to, right, the interaction of the person, the environment, and the task, right? And so really the take home is that evidence-based theories and principles, right, are being utilized, right? And we're able to utilize these through virtual rehab and technology. And so, it's working. Our patients are getting better. So, my take home is to continue learning, right? Keep exploring options, and let's just keep moving our field forward. Yeah. Because like you said, you're right. I would have never imagined I would be in this role 20 years ago, because it didn't exist. And so I think that's what we're going to see on the horizon. There's other roles that don't exist yet, but they will. And so, and follow your heart and your passion. What really brings you joy, that's what I did. And that's what kind of landed me here. Yeah.
Oh, well, Katie, thank you so much for being here today, for sharing about yourself and about your work and this vision for what's possible. And like you said, I just hope the access continues to increase and we as OTs can be part of that and part of those teams. And I just thank you for that push in this conversation today.
Yeah. Thank you, Sarah. It was such a pleasure. Thank you for having me. And, I've been part of OT Potential now for a few years, and I really appreciate all the work you're doing and helping to, advance evidence in our practice and really being a thought leader. So thank you for inviting me.
Wow, you all, this is such a complex topic. We tackled a lot. We dove into how theory should drive neuro rehab and how technology is needed to bridge our current gaps in neuro rehab. Luckily, Katie's story made this complex intersection just feel full of possibilities, and I hope you are leaving feeling just full of hope and possibility for your patients and also for your OT career. And as always, we want to hear what your thoughts are on this episode. If you are a casual listener, we would just love a review from you. You can review us on our homepage, or we always appreciate your comments on our YouTube video. But the best place to really discuss the implications of this is in the OT Potential Club, and I'll be watching for your comments in our forum. The OT Potential Club is also where you will go to earn a CEU certificate for your time today. So what you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test. And when you pass, we will generate a certificate for your time today. Okay, I want to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.